Uh, Thank you for your attendance here. I hope you had your lunch. I didn't have it. I do receive research grants from Alcon Laboratories, but has maybe some interest that I'm using the machine and going to show that machine which I use from that company, but otherwise nothing specific. I think it's been recognized very well, and I endorse that it's very easy to perform, but the best part is the predictability. And it is a predictability, in other words, you should be able to reproduce it every time you want to do a procedure. And that differentiates as a surgeon from other people and the technology from other technique and so on. And of course, it has to be quite precise. So that's an appeal. Now, we do know, and I think it's been accepted, that the value of flex, femtosecond assisted cataract surgery, is okay in the spatial situations. And I'll go through that spatial situation. But not very many understand that it is very useful in routine cataract also. Although the routine cataract could be different definition of routine in your particular geography than mine, but whatever the routine cataract is, if it works predictably well, that's what you want, the technology, the skill, and whatever you have. And that's where I think the femtosecond flex capsulotomy has an advantage, that is going to work every time. And then other thing is that you can combine some other techniques like pre-chopper in the flex. This is not related to the capsular axis, but and you can do perhaps with the with some other thing, but with the devoted machine like Zepto and others, you can't address that. So I think this is one more advantage of flex and not rexes, that you can combine pre-chopper and whatever all other technique is, because what we are looking for is a consistency or predictability. We did a study before we decided to buy the LensX I had. I was late to buy this machine. Probably I was 17th or something like that in India, and 2.5 years later of the innovation that I bought this machine. And before we wanted to understand how valuable it is. So I did consecutive 100 rexes, and I could not complete in one continuous. My junior consultants did 94 out of 100, and my senior fellow, which were, year and a half, they could do an 89. And that gave us a bell to us that, why not 100%? So I can vow that these flex-assisted rexes, whichever the company you have, will be able to produce 100% in your routine cataracts. I'm convinced. Question is the money for which you need to pay for this 100%, or that remaining 1 or 2%. So clinical and optical significance of centric rexes is understood, although I must say that the rexes centration is not perfect in all of these flex. It's not terribly better than Zepto or other things probably, but maybe better than manual in some hands. Now, the whole philosophy of this femtosecond laser assisted is good because it is done without opening the eye. So when I talk to my patient, I generally don't canvas for this procedure, but I do about 40% or more of cataract surgery by using this technology. And if I'm putting a corner, what would you say? I would say this is safe, a little bit safer compared to any other technique you have, because the eye is not open and these steps are done with the precision and almost 100%. So that sort of thing is good for a surgeon. And I see I have a variable caliber of surgeons. I have fellows, I have a junior consultant, my children. Their confidence has boosted up so much because when they sit on the chair, the rexes is already performed and the division process is already assisted to some extent. So that translates into the overall confidence, which will give a good control on the performance of the remaining part of the cataract surgery. And I'm convinced that this is a great way to do this. The real bugbear is the money, and I have no answer to that. So those who are fortunate to have enough resources consider that LensX or the femtoflex induced, and you can certainly now go for Zepto because wonderful cases I saw just now. So these are all similar things like what you saw earlier, and the only difference is that the bridges would happen in this also. But these bridges will be smaller and more easily manageable compared to some other techniques. But they can occur there. This kind of thing is not very common that it will truly float in the chamber, although it is totally detached. It doesn't literally get lifted up every time. But this is one of the rare or uncommon cases that happens there. And then you need to stain that capsule to see in case there are microbridges. And imagine there are microbridges and do that. Although this is a totally detached thing because the capsules are very fragile, and Trypan itself can also make it a little more fragile. And Trypan issue, I just got a knowledge. A guy from UK told me, Sanjay, that Trypan are being questioned now beyond the limit concentration or time because it's found to be carcinogenic in the long run. So I don't want to scare you, but there are surgeons who do hydrodissections, and they use Trypan blue very generously in retina and not Trypan blue, Trypan blue, yes, in the cataract surgery. Retina they use the other one. But so in other words, these can make it, and microbridges are more easy to handle than the big ones. And small pupil, there is a limit, of course, and you can do it any pupil, but then obviously you will end up with capsular fibrosis, and you will have to use the retractors. Some people use Malugni ring or Bhattacharya ring or somebody, and then do Rhexis. But I just do not use those things, and I do not perform that Rhexis if the pupil is smaller than what you're seeing here. But if it is that kind, this is not bad at all, and you can really do it well. And then what you need is to just pick it up with that, and you can achieve a good performance there. It's not a big thing, but it is this one. If I have to single out one advantage which is so meaningful to the humanity, is this application of this flex Rhexis in anterior and posterior capsule in children. Because if you do both Rhexis and if you capture, you don't need to do vitrectomy. That's what we do. I don't do flex most of the time in pediatric because I have to use 2 PIs, so expensive. But if you can do that, now with the principles of optic capture, we published an article in September issue or October issue of last year where we did capture with no vitrectomy and conventional in the bag with vitrectomy. So the flex capsulorhexis is really a boon, but like the paradox of life, this is where the patients don't have the money. But the thing is that it is easy to perform it under GA, and you can produce a Rhexis of your size and your choice, centration and whatever, and you can really do that very well. And the thing is, as I told you earlier, this is a PCCC performed by LensX, and I will not do Rhexis, not do anti-vitrectomy, and I will just capture the 3-piece Acrisoft. You can use whatever lens you want under that Rhexis, which is through that flex-induced PCCC. So the question is, what you find in the bench or in the laboratory, the strength of the Rhexis, the ruggedness of the Rhexis. Luckily for this technology, in clinical scenario, it is sufficiently strong to withstand the retractors you can pull it for the sublux cataracts or capture through the small Rhexis. So that is true, and the laboratory science has to be correct. But for a clinician, it is an information. I will keep it in the back of the mind. So that's how the thing I see. And you can do with some opacities. We do a lot of arcades. I mean, some arcades are terrible. You can't do it but most of the arc is done sensibly or with the pterygium and sort of thing. You can produce that and address that thing, and including if you're an ICL and you can recognize that ICL there, you can perform that. You can also take advantage while you're performing rhexis after doing that, breaking the IOLs also and make some cracks so that with a small incision you can remove the ICL, which goes through small anyway actually. So this is the same patient with you saw there, and then you need to enlarge this one because you want to remove that more than 2.2, and then you have a choice. Remove that ICL and then the rhexis. So this can be combined, as I said earlier, with various maneuvers of lens removal and this kind of little thing. I'm doing it with pre-chopper. That's not rhexis contribution, but the technology. So I think if you are affording, or if you think it is viable, and that's the key question, is sustainable in your practice, the patients can appreciate that consistency and a slight safety, this is worth. Well, presentation is still an issue, and many times with this view, and there are other machines which give some different views. All of these have some issues of concentration of different kinds, but you can end up with some part cover and not total cover, or just a minimal cover and one and thing, as we say. So what does the literature say? I think there are literature, and Sanjay mentioned that